So the last time we talked about circulation issues, before I went off on the tangent about my transesophageal echo yesterday, was arterial occlusive disease or peripheral vascular disease. And to kind of summarize, that's peripheral vascular disease is asymptomatic, no symptoms, does not need treatment. Intermittent claudication may or may not need treatment, usually handled conservatively, generally has a very benign natural history, or critical limb ischemia, which needs intervention for salvage of the limb because patients with critical limb ischemia are at a higher risk for limb loss, and therefore in that situation they need some type of intervention performed to salvage their leg. And so that's the spectrum. These are all, generally speaking, more of a chronic nature, meaning that you don't progress from asymptomatic peripheral vascular disease to critical limb ischemia all of a sudden, generally speaking. So chronic peripheral vascular disease versus acute arterial insufficiency. Acute arterial insufficiency means you find 1 minute, next minute all hell breaks loose. And so that is evaluated and treated more urgently, okay? So the symptoms of acute arterial disease will be something like this. Walking fine, not having any problems, and all of a sudden I get this sudden onset of severe pain in my leg, and it progresses to the point where I have numbness over my foot, can't move my legs. So then you're concerned more with acute arterial occlusion or acute arterial insufficiency. That's handled differently. Why? Because if you get to the point where you're losing motor control, that's really an ominous sign. So, when you're in school, in your training years, you learn about the 6 Ps, and I can't even remember if I know them all: pulselessness, pallor, paresthesias, pain, and 2 other Ps I can't remember. Really, this is just medical student kind of general surgery residence stuff, which really is not that important. So whenever I ask residents these questions, they give me the 6 Ps and they know them off by heart. I can't even remember them. The key is loss of motor control. So when I teach the general surgery residents, I say, if you get called to the emergency room for a patient with arterial insufficiency or arterial occlusion, and you think it's acute versus chronic being the critical limb ischemia and all that stuff, acute arterial insufficiency, can they move their foot? That is the key, not the numbness, not the paresthesias, the kind of the funny tingling, whatever. It's can they move their foot? Because if you lose motor control, then it really becomes an emergency. The classic teaching is if you've lost motor control and you have 6 to 8 hours from onset of your symptoms, then your risk for limb loss starts really going up exponentially. That's why loss of motor control really takes precedence. So you get called, somebody in the emergency room, or for the general public, your foot really hurts all of a sudden. Then you can't walk because your calf locks up on you. Then you have to worry more about acute arterial insufficiency, and it's kind of an emergency. So why do people get arterial insufficiency like that all of a sudden? 1 minute they're fine, next minute they're doing terrible. Well, it could be that they have severe peripheral vascular disease and all of a sudden something major occludes because of the low flow, and they weren't that symptomatic beforehand because they weren't exerting themselves. All of a sudden it's hit that critical stage and they need something done because they're getting such poor flow down to their foot that their foot is really hurting them and they're losing motor function again. So acute, we'll call acute on chronic events, okay? Number 1. Number 2, you have a patient who has an irregular heart rhythm, so, like atrial fibrillation, irregular heart rhythm. The atrial fibrillation is where the top part of the heart just kind of beats irregularly, and some of those beats are transmitted to the bottom part, some are not. But the problem is when you have that irregular heart rhythm like that, it predisposes you to developing blood clots in that fluttering portion of the heart, which can break off, flip through the heart, the left side of the heart, and end up down somewhere in the circulation. So a filtering system ends up in the legs, and you have acute arterial insufficiency, the pain and paresthesia and all that paralysis. Once you get that paralysis stage, that's a big deal. So clots that are thrown off to the lower extremities. Now, to separate this from deep vein clots. Vein clots don't usually do this. Vein clots usually just go up through the heart and then flipped into the lungs. Unless you have a hole in your heart, which doesn't, maybe it's about, I think about 5 to 10% of people. Typically, the clots in the veins end up in your lungs. These ones end up in your legs. So arterial insufficiency from irregular heart rhythm can be a source for it, or from an abdominal aortic aneurysm or aneurysms in the abdomen. We'll talk about aneurysms in a separate setting. Aneurysms are enlarged blood vessels, and one of the consequences of having a large blood vessel is you can form clots inside of that area there. And so some of those clots can break off and go to the legs, arterial insufficiency, or acute arterial insufficiency, or you can have clots behind the knees, so-called popliteal artery aneurysms. They can develop clots in the aneurysm there, and that can break off and go to the leg. So there's a whole host of things that can do these acute occlusions. But the key is, in the evaluation, is if you've lost motor control, that's a much bigger deal. That really needs to be assessed more quickly and treated more quickly, often by fishing the clot out of there, either with endovascular technique with an angiogram and kind of suction it out, or open surgical removal of that clot to reestablish the blood flow down to your legs. Because past 6 hours, the complication rate really starts going up in terms of return of function, in terms of swelling of the leg, so-called compartment syndrome. We end up with a whole bunch more incisions. And so if you can capture this stuff early and treat it, it's a much better way of handling it. And then you avoid all these other potential complications. So that's acute arterial occlusion. I'll kind of get into that in more depth at a later date. Just save it to say, for the medical students who are watching this, or surgery residents, numbness, pain, pallor, paresthesia, blah, that's all wonderful. But if you're losing motor function, that's a big deal. So always assess the motor function. Always assess the motor function of the foot. And as you know, the residents and surgery and medical students, the anterior compartment of the foot, the one that pulls the foot up, that's often the first muscle group that's affected by ischemia or lack of blood flow. And so if you have you start having trouble pulling your foot up, just watch out for that. That's a telltale sign that you're getting. Now, there's other things that do that, but if in the setting of an acute arterial occlusion, that means you have to move fast.